I'm going to present a paper which we have published. As we have heard from the prior presenters that the smaller you are, the more likely you are to have the immediate risks as well as the long-term risks. So but now the next question will be, so how do we diagnose these small babies, right? Because the past decade, the market has been flooded with lots of growth charts, with lots of references, right? So we wanted to do a study to try to decide of all the charts or the references which are in the market, which one should suit our population. So we did a study where we wanted to do a comparison of different charts and see which one would suit our population. So as a form of our introduction, we all know that the charts which we are using to estimate, which we are using as a reference, which is the Hadlock chart, it usually comes as a pre-installed chart in our ultrasound scan machines. But we all know the limitations of these charts. Number one, this chart was done on the Caucasian woman. They did in about 392. So you can already think about the problems which you might have by using such a chart to say, do these fetuses of this Caucasian woman grow in a similar way to our own population? And other population have tried to look at other different charts to see which one can suit their population. And in other prior studies which have been done, it has been shown that by using this Hadlock chart, it will result in maybe overestimating or underestimating these fetal growth fetuses. And we all know the implications and repercussions. For example, if you are to overdiagnose this fetus with their fetal growth restriction, we all heard of the follow-up which need to be done. So that means we're going to strain even our healthcare in trying to follow up this fetus with fetal growth restriction. At the same time, if you fail to pick them up, we're going to also see some of the consequences which are associated with missing these babies with fetal growth restriction. So the growth charts, they've been compared in other populations, but in Zimbabwe, no similar study has been done before to try to see which chart can suit our population for us to make a diagnosis of small for gestational age. And during our local scientific meetings at CISOG, Zimbabwe Society of Obstetrics and Gynecology, people have been raising questions to say, sometimes the fetuses are being scanned, the scan saying everything is okay, but come delivery, we'll get a better outcome. So people were saying, is it because of the charts were failing to pick up these babies' fetal growth restriction, or should we adopt another different chart? So we thought we should do this study to try to look at a chart which can best suit our population. So we were comparing different charts to this traditional Hadlock, which we use every day. So the main objective was to compare the performance of international growth charts in diagnosis small for gestational age and the possible impact of adopting other charts. We were saying that if we are to move to another chart, what are the impacts of doing that? So we first did this step to try to look at how the other charts would compare in trying to diagnose small for gestational age. So this study was a cross-sectional cohort study, which we did at our two main central hospitals in the government sector, which is Parenyatwa and Harare Hospital. And we collected data from the fetal medicine units database. And we were collecting only women with single fetuses. We're not looking at twins. We know other problems which come along with twins. So we're just checking for women with single-tone fetuses. We had an ultrasound scan between February 2019 to March 2020. So we were analyzing those who were diagnosed with small for gestational age only. We didn't look into those with appropriate or with large for gestational age. So basing on the Hadlock formula, the diagnosis of small for gestational age was based on the 10th percentile. But we also went ahead to further look into a class of those who are severely small for gestational age. That means those who are less than 30th percentile, and try to compare among the different charts what is the pickup rate for the different charts. So, and also to look at the implications of switching. So what we did was we were using proportions to check the pickup rate of different charts. So we would collect the biometry of those babies in the heart-log chart. That means the head circumference, abdominal circumference, as well as the femur length, right? Then we'll try to create another fetus using those biometry on a different charts and try to see whether that chart, let's say the baby was classified as small for gestational age using the heart-log. We would take the parameters which are there in the system to say what was the head circumference, what was the femur length, what was the abdominal circumference, and to put those measurements in another chart, because the wood chart is also there, the intergrowth charts as well as the CF, EF charts are also there in that machine. Then we'll try to see whether that chart is going to pick those babies as small for gestational age. So what did we find after doing that? Because it was quite cumbersome. So what we noted was that we had to analyze about 303 cases for that period. Those were diagnosed as small for gestational age. And it's less than 10 centile. We noted that the wood chart could mirror the standard heart-log. But if you are to further categorize our small babies into severe, that means those who were less than 30 centile, it was the intergrowth chart which was best in picking up the babies, as I'm going to show you in the following charts. So if you are to look on our further left, if you are going to plot those babies from heart-log, which were said to be small for gestational age, look at that. The wood chart could pick almost all of those babies, and just a few were above the cutoff centile. That was for the 10th centile. And if you go on the further right there, where we're looking at those who are severely small, we know the problems with those who are severely small. The intergrowth could pick the majority of those fetuses, and just a few were above the 3rd centile. Now, going further with our analysis, we did also a blind outment plot. So with this plot now, you will be comparing two charts. For example, in the first left there, we're comparing the heart-log and the wood chart to say, if we plot all the babies who are small for gestational age, how many of them would lie outside the agreement limits? And you can check for yourself that only 14, if you are to compare the heart-log and the wood chart, only 14 of the babies would fall out of agreement, which means the wood chart is almost similar to heart-log in picking these babies. And if you are to go on the further right, where we're comparing for those who are severely small with a blind outment plot, only 10 of them would lie out of the agreement, which means the majority of the fetuses were picked up by that intergrowth. Now, going further, we wanted to summarize the charts about the pickup rates. And if you are to summarize these charts, we're starting with the heart-log. At less than 10th centile, because these were the fetus which were picked by heart-log. So it was 100% because we just took those who were less than 10th centile. If you are to put other charts which are international, like the WHO, we can see that it picked about 273 of those babies, about 90%, which was way ahead of other charts, the intergrowth, as well as the CFC. So you can see that the wood chart could pick the majority of the babies who were small for gestational age. But if you are to further classify these babies, to say, let's zoom in and look into those who were less than 30th centile, which chart could pick the majority? You can see it's another different chart now. So we would need to sit down and agree on to say, if you are to use this center, which chart is best? But if you are to agree with the majority to say for less than 10 center, it is the WHO which could pick the majority of the fetuses. Now, so in conclusion, from this study, we would note that if another chart is to be used to screen for the babies small for gestational age, we should adopt the WHO chart. If we are to aim for which we are saying for less than 10th center. And this would indicate that if we are to transition from Hadlock to the WHO chart, is relatively a safe alternative, since the WHO chart managed to pick the majority of those fetus who are small for gestational age. But we would want also to recommend that a similar study should be done for those babies who are small for gestational age, who are large for gestational age, as well as appropriate for gestational age, to check whether this chart would perform similar if you are to look for a baby with appropriate for gestational age and large for gestational age. So I want to thank you for the time and the opportunity. Back to you, Chair.